So hello, everyone. We are here for a new EasyChem chat. I have the pleasure to discuss today with Professor Jacques Reteau, who is my head of department. Hi, Jacques.
Hello, Fabio.
We are physically not so far, but for the COVID restriction, we are in two different rooms in the hospital. So today, Jacques, we are going to discuss, because we discussed a lot about COVID in the chat, especially about therapeutics, but I would like to talk with you about more, let's say, specific point, which is the ethical issues. And the first question, would be one big challenge in terms of ethics, have been the ICU bed availability. How this has been managed in terms of ethical concerns?
You're right, Fabio. Thank you for the question. The first thing is that very quickly during the pandemic, we were the ICU bed offers was too small to accept all the patients with COVID-19. To manage this, we had to use some clinical, triage tools. It's very important to understand that when you are working in the hospital, there is some rules that you must respect for these triage tools. First of all, the rules must be very explicit. The triage tools must be constructed with the other doctors from the hospital to accept those rules. And if those rules are clear and explicit, you can work in transparency in terms of those rules, which is very, very important. Otherwise, this will result to a lot of conflict between doctors in the hospital.
Can I ask, some people at the beginning, especially at the television, newspaper, said that the age was one of the criteria we have used, but then we realized that age is not enough.
We construct our own tool to guide triage for admission in the ICU, and in fact, we didn't include age. We prefer to include frailty score, and even with it counts for 2 pounds let's say, to put the accent on frailty more than on age.
And there is another point which is also very important in terms of ethics, because at the beginning, everyone tried to create additional ICU beds because we wanted to take care of the most of the patients we can. We shut down the activities, and all the ICU were almost only COVID patients. Do you think that, ethically speaking, this has created some reduction of quality of care somewhere?
Yeah, I'm sure that we must accept, in fact, that when you increase the number of beds, you will, of course, reduce the quality of care, because it's easy to have enough material, enough respirator, but it's much more complicated to have nurses at the bedside with ICU expertise. And of course, you must accept this, because otherwise you do not have beds. It's more important to have a bed open to have a patient in the bed with a nurse. At contrary, if you have no nurse, you cannot open the bed. But clearly, you have to accept that you will decrease the quality of care. That's it.
There is also another point that is, I think, very interesting. You have said that we use some scores. So in this score, there's the frailty, comorbidity. So we make some selection of patients. So, we are in Belgium, we are quite open to discussion of ethics. Some other countries, the ethical discussion were more problematic. I just wonder, do you think that the most vulnerable patients, the elderly, those with cancer, those with chronic diseases, were those who suffered from the COVID pandemics because they were the most vulnerable, were not admitted to the ICU? Or do you think basically this is what we do already in general practice?
You are right, Fabio. The public has discovered the problem of triage ICU during the COVID-19 crisis, but in fact, we do that, all the years and before the pandemic. But of course, due to the great number of patients, at the door of the ICU, we were forced to use more strictly those criteria. And I want to add something else, because that's very important. Probably we forgot this. In fact, at least during the first wave, we were facing a new disease. And it's sometimes very, very complicated to make any prognostication on patient when you don't know the disease, you don't know, the natural cause of the disease. And in fact, ethically, it was very, very complicated to do that.
You mentioned before that it's important to include non-ICU doctors in this ethical decision because when you are everyone is all the hospital is packed of patients, you cannot go and make decision with all the patients in the hospital. Was this a difficult task to do with people who are not used to discuss about ethical decision immediately, or was something that worked quite well?
In fact, if I can make a point, what we use in Erasmus, so it was a score for admission. And everybody knew this score, and even people working on the floor, the internist, doctor, for example, and each day we readjust the score depending on the free bed in the ICU. So they are, aware of the, the number of patients in the ICU. So we are working together, and again with transparency, with a very clear set of rules. You can avoid a lot of conflict. When you have times, of course, you must also try to implicate the general practitioner who knows, of course, very well the patient, and that's very, very important. Try to do that.
Now, when we move over the pandemics, with the new therapies available, vaccination, whatever, there is another new ethical issue, which is, do we need to keep a specific number of ICU beds dedicated to COVID? Because if we do this, we can potentially be detrimental for non-COVID ICU patients. So at the beginning, everyone did it because there was a lockdown, there were no other diseases. Now that everything is open, we're still facing non-COVID ICU admission. Do you think it is ethical to dedicate in the ICU a specific number of ICU beds to COVID? Or should we work on general criteria, including COVID and non-COVID together?
As you know, in Belgium, we have since a few months alerted the authorities to abandon the concept of, let's say, reservation beds for ICU for COVID-19 patients, because clearly it impacts the quality of care for non-COVID-19 patients. And so I think that we must learn to live with the virus. We must live with the COVID-19 disease. And in this case, of course, please do not reserve a specific number of beds for COVID-19 patients, but see the concept of ICU triage globally with the COVID-19 patient and the non-COVID-19 patient, because otherwise it's not ethically good for this.
There's also another new ethical challenge. Maybe we didn't observe this in Belgium, but I at least discussed with some colleagues in other countries. With the polarization of the debate on COVID, people who are against vaccination, they're starting to be against care. They think that, endotracheal intubation will kill them. And we see now people admitted to the hospital who refuse, life-saving care. How can we manage this? Is it an ethical decision? Should the patients be the only one who decides? Or if there is misinformation, we can still go over his decision and still provide her the adequate care.
Fabio, you know my point on this. I think that the first principle of ethics in medicine is the autonomy, and I agree with you. If you put this criteria as the first principle of ethics in medicine, of course the patient must be informed, but we inform with the good information, and that's a problem, of course, in the pandemic, because a lot of fake news have been spread on the networks and in the but unfortunately, I think that you cannot go let's say and ignore the advice of the patient. The autonomy still stay the first principle in ethics in medicine.
You mentioned also before withdrawal of care for patients where there is no response to therapy. At the beginning, you said we didn't know how to do it. Now we know that these COVID patients can remain for a long period,
several weeks,
a few weeks, sometimes in ECMO even months. Do you think that we have changed the way that we drove care? Do we do it too early in COVID? Are we still learning? Do we have criteria to do it?
That's a good question, and I'm not sure that everybody has the good answer here. We, of course, first of all, I think that the population were admitted wave by wave has changed. In fact, we have more severe patients in the ICU now than in the first wave. I think that we must continue to apply general rules on, the aim of ICU. The aim of ICU is, of course, to save life, but save life with a good quality of care when the patient will be outside the ICU. We must apply the same policy in COVID-19 patient. But I agree with you. It's sometimes difficult because those patients will stay several weeks in the ICU. And I can make a comment on that because you know that we sometimes use what we call ICU tests in patient, let's say when we don't know if the admission in the ICU will benefit or not to the patient. It's easy, even in severe septic shock, you can assess after 2 or 3 days if the patient goes to the right direction or not. But in COVID-19 patient, you are sure that after 3 or 4 days, the situation will be the same or even worse. You cannot say at that time that you will stop or continue the treatment. And that's a different thing with the COVID-19 disease.
Maybe last 2 points, rapid point. How much do you think family should be involved? How much family has suffered from the limitation related to COVID-19?
That's a good question. Everybody, all the caregivers were, very sad to do not have the family at the bedside during this crisis. Almost all the hospital restricted or forbidden the family visit, and I think it was a major challenge to, in this condition, to implicate the family in the end of life process. But what we learned during this COVID-19 crisis is that we didn't want to have patients dying alone. So we invite the family to come when there was a deterioration of the medical situation for the patient. And in fact, we organized meeting with the family. And that's important because if we can learn something with the COVID-19 patient, the COVID-19 crisis, is the fact that it's more important, it's very important to try to organize meeting with the family. And I hope that when we will finish this experience with the COVID-19, we will continue to do that because the efficiency of this meeting, organized meeting with all the caregivers, the nurse and the doctors is very, very important.
Jacques, I want to thank you for your points. I think ethics is sometimes difficult. We don't have ethics course or lessons at university. We have to learn on the field. And you make very good points, underlying even the differences with other countries. And we are still learning about ethics in this terrible disease. Thanks a lot for your participation and see you in the next EasyChem chat.
Thank you, Fabio. Thank you.
Bye-bye.
Bye.